So this will be a case talking about a little bit of supernova and DSI. All right. I have an elderly woman sent out to me. All she needs is a UA to confirm or rule out UTI, CAT scan of the abdomen if it was negative. She's found to have be 80s, in her 80s, 90, with blood pressures hovering over 90 to 100 systolic, tachycardic, goes up and down with fever, baseline dementia, and families hasn't called back. So we're kind of stuck in being aggressive for this patient. She gets tachypnic. We're holding off intubation with BiPAP, which she's doing well on. The UA does come back dirty, but to make sure it's not an obstructing stone, I did a CAT scan. It wasn't a dry CAT scan. It was with IV contrast and found to have an obstructing stone in the mid-ureter. Urology is called. She needs to go to the OR. But in case she craps out in the OR, urology asks us to put a central line and intubate this patient. Now, this patient's at baseline slightly demented. Maybe with the sepsis, more lethargic, but she's arousable but confused. We try to put on a non-breather mask, and she does what's to be expected from a demented person: look at me funny and grab the thing, and pull it off. Somehow she doesn't take out the nasal cannula. I have two residents, a PGY3 and a 1. One resident's holding down her hands to prevent her from removing the oxygenation again. Now, she's not cooperative. She has sepsis. So, I have to figure out, what am I going to do for intubation? I'm holding off on etomidate because I know in the first 8 hours it may cause some adrenal suppression, and she does have sepsis. She does have a 105 fever earlier, documented 103 fever, tachycardic with some lethargy, AMS. One episode of hypotension recorded when she first came in, and later on not hypotensive for now. So I'm going to decide to give some ketamine. The issue is she keeps refusing or cooperating to maximize oxygenation. So guess what? Instead of giving some fentanyl, ketamine, and rock, I decided to give the ketamine up front. Why? This is kind of like inspired by Dr. Weingart's thought of DSI. So she weighed around, she raised her one up. She's a little chubby, a little short, but she's very round. So I thought she weighs around 60 to 80 kilos. So whatever math you use, it either winds up being 1 to 1.5 milligrams per kilo. I wound up just giving something straight up like 70 milligrams of ketamine. Now, giving that dose, she got nystagmus and no longer started to pull away on the oxygenation. Okay, but since I have a supernova on me, I decided to proceed and use it. I took off this part of the nasal cannula, decided to put that on this port for oxygenation's sake. Okay, put this on. So the 15 liters that was going in before goes on through this. Alright, so I put this on her. Take this off because this is no longer needed if I'm going to use this device. Alright, so open this up. Put this on the patient. Alright. Now, this is a relatively new device in the emergency room. Alright. Put this on. Respiratory is looking at me funny as well. But I'm able to put this on. Alright. She's cooperative. I haven't given her any fentanyl. I haven't given her any type of rock. The fentanyl is mostly to suppress some of the catecholamine surges that can happen with that manifests in tachycardia, ridiculous, exaggerated response with hypertension. during the administration of ketamine on the elderly. And that's what I'm trying to avoid. Now she's cooperative. All right. Now some patients are mouth breathers, right? And that's the only reason we try to put on the oral piece of the supernova. All right. It's hard to assess right off the beginning. Some patients you can actually push and close the mouth completely, and some patients you can't because they have baseline trismus, baseline malocclusion, or TMJ disease. So I put this on so there's a seal, so they won't, all the oxygen that I may be providing through BVM won't be escaping through the mouth. Okay? Intubation was done with a glide scope, 1 shot in, no problem. She did not desat at all. The one thing I had to be cautious about is hypotension, because remember, we're going from her own diaphragm controlling her breathing to now she's sedated and paralyzed. Now I'm providing positive pressure, increased intrathoracic pressure. BP did drop. So we gave her a bolus of fluid, 1 liter, and started some Levofed to maximize at least baseline a systolic blood pressure of like 100 over PAP or a MAP of 65 or greater. She survived to make it to the operating room to get emergent decompression. Either she was going to get a perk or she was going to get a stent placed emergently. But she was dying of uroseptic shock, sepsis from UTI complicated by ureteral stone. So one thing I did advise my residents, look at your shock index. That will predict that hypotension may occur. And despite the fact that people talked about ketamine not causing hypotension, it may happen. And I think it's when it's the extremes of the sympathetic crisis of her having septic shock, severe sepsis, that those patients I think teeter around becoming hypotensive regardless of what you give them. She wasn't having hemorrhagic shock, not yet, and she only had hypotension in the beginning, hours before it was signed out to me. So just be very cautious. Try to use your shock index. If it's towards 1 or greater, be very suspicious. The greater the ratio of the heart rate over of the systolic blood pressure, the more likelihood that you're going to get some hypotension afterwards, regardless of what you give. Okay, hypotension can occur with ketamine. Some will argue, why did you give the fentanyl? It's almost preparing her for post-intubation sedation. That's why I do it. Some will argue, why are you giving the fentanyl? Why not deal with that later? That's a valid point. I'm just trying to learn different ways of providing RSI on our sickest patients. Thank you.